If you break an arm, right, the fix is fundamentally mechanical. You look at an X-ray, you see the jagged white line, you set the bone, and you put it in a cast.
Right, it's very straightforward.
Exactly. It's essentially carpentry. I mean, the problem is visible and the solution is binary. But when you step into the world of female regenerative medicine, doctors aren't playing with wood and nails.
No, they definitely are not.
They are trying to reconstruct living, breathing, constantly stretching tissue. And historically, if we are being completely honest here, that landscape was, well, almost entirely guesswork.
It truly was. I mean, practitioners were essentially flying blind for a long time, just borrowing techniques from other areas of aesthetic medicine and just hoping they would translate to gynecological tissues.
Which is wild to think about.
It really is. But the shift we are seeing right now is profound. We have moved out of that era of, like, diagnostic muddy waters and into a space of highly precise, almost astonishingly mathematical science.
Which brings us directly to the mission for today's deep dive. We are looking at the exact biochemical recipes used for submucosal vaginal remodeling.
Yes.
And if you are listening to this and wondering why a doctor would need a math degree to perform tissue restoration, well, we're going to break that down for you.
We've got a lot of data to get through.
We really do. We are pulling from a massive stack of clinical trial data, medical conference notes, and strict product guidelines. We're looking at fillers like Deserial, Novia Rose, Regenular Ammonia, and FGYN.
All the heavy hitters.
Right. And our goal is to demystify exactly how gynecological experts are using specific product concentrations, specifically leaning into this 20 to 25 milligrams per milliliter sweet spot, and the highly exact fluid volumes required per session to achieve real functional tissue restoration.
Exactly. Because this isn't just, inject and hope for the best anymore.
Yeah.
Whether you are a medical professional trying to understand the nuances of these protocols, or someone navigating this medical space personally, or just someone who is insanely curious about how far regenerative medicine has come, understanding the sheer precision of these treatments is, well, it's eye-opening.
It really is.
The entire field has realized that you have to tailor the biochemistry perfectly to the biomechanics of the female anatomy.
So let's start with the core material itself, because everything hinges on this. The main ingredient across all these sources is hyaluronic acid, or HA.
Yes, HA.
Now, I think a lot of us hear hyaluronic acid and we think of like a serum we buy at the pharmacy to moisturize our face.
Right, the stuff in the dropper bottle.
Exactly.
Yeah.
But looking at these clinical trials, the HA they use for remodeling is definitely not a simple one-size-fits-all gel.
Oh, not even close.
Yeah.
The HA used in these procedures is a very complex structural matrix, and the most critical variable is its concentration.
Okay.
When you look at the clinical guidelines, the concentration is always measured in milligrams per milliliter, or milligram per ml.
Yep.
And that specific number dictates how thick the gel is, how much it stretches, how much water it pulls into the tissue, and how well it integrates with the patient's own cellular structure.
So they can't just wing it.
No, a practitioner simply cannot grab a random syringe off a shelf. They have to match the physical property of that specific gel to the exact anatomical need of the tissue they are treating.
Okay, let's explore that spectrum because the sources detail a very wide range of concentrations. And I want to figure out how doctors avoid turning sensitive tissue into, frankly, a rigid lump.
Yeah, nobody wants that.
Right. So if we look at the lower end of the spectrum, the data mentions a 19 milligram per ml concentration. What is that actually doing?
So 19 milligram per ml HA filler is quite light. It is typically used for what the medical literature calls moderate hypertrophy, which essentially means, early stage tissue thinning.
Okay.
Because it has a lower concentration of hyaluronic acid, it integrates very softly. It doesn't provide a massive amount of structural support, but it delivers excellent hydration.
Ah, I see.
Yeah, the HA molecules act like tiny sponges, binding to water and restoring a bit of the natural plumpness to the superficial mucosa.
But then you jump to the completely opposite end of the spectrum. The sources mention products like Numavia Rose, which go all the way up to a 28 milligram per ml concentration.
Right, that's a big jump.
It is. And looking at the chemical breakdown, it's not even just pure HA. They are mixing in amino acids like glycine and L-proline.
Right, because at 28 milligrams per ml, you are dealing with a totally different clinical problem. That high of a concentration creates a very dense, highly viscous gel. It is specifically reserved for severe lipoatrophy.
Wait, pause for a second. You just dropped lipoatrophy. I hear atrophy and I think of like muscle loss. What exactly is lipoatrophy in this context?
Oh, great catch. So lipo refers to fat.
Okay.
So lipoatrophy is the severe loss of the underlying fat pads, particularly in the labia majora. When those fat pads diminish significantly due to aging or hormonal changes, the tissue it loses its foundational architecture.
Wow. Okay.
Yeah, you can't just hydrate that area. You have to rebuild the scaffolding. That's why a 28 milligram per ml concentration is used. It provides significant structural volume.
And the amino acids.
Right, those added amino acids, the glycine and L-proline, those are the essential biochemical building blocks the body needs to form new collagen. So the dense gel holds the space open, while the amino acids encourage the body to build its own permanent support structure around it.
Okay, I'm thinking about this like mattress memory foam, right?
Okay, I like that.
Like if you buy a mattress topper that's too light, like that 19 milligram per ml, you might just sink right through it if you need real back support.
Exactly.
But if it's way too dense, like the 28 milligram per ml, it feels like sleeping on a piece of plywood. It's structural, sure, but it's totally unnatural for everyday movement.
That is actually a spot-on analogy.
Well, looking at the bulk of these clinical guidelines, they consistently point to this 20 to 25 milligram per ml range as the ultimate sweet spot for comprehensive remodeling.
Yes, they do.
So if 28 gives the most structure, why are doctors specifically aiming lower for most procedures? Is it just about mimicking natural tissue rather than just, I don't know, stuffing it full of volume?
It is 100% about mimicking the natural tissue biomechanics. I mean, the vulvaginal tissues are highly dynamic. They require flexibility, constant hydration, and movement.
Right.
If a practitioner uses a product that is too highly concentrated and cross-linked, when the patient only has moderate tissue loss, the result is terrible. The tissue will feel nodular, stiff, or just completely unnatural.
Because it's basically fighting the natural movement of the body.
Exactly. It's essentially putting a rigid block inside a flexible space. That is why the 20 to 25 milligrams per ml range is the gold standard for most submucosal remodeling.
Got it.
For example, the sources mentioned 2.2% gels, which equates to 22 milligrams per ml, like FGYN, or pushing right up to 25 milligrams per ml with products like Regeneol Armonia.
Okay.
At this specific density, the manufacturers use a gentle cross-linking process to create what they call a 3D matrix.
Okay, a 3D matrix. That sounds like a marketing buzzword. What does that actually mean under a microscope?
Fair question. It means the hyaluronic acid chains are linked together in a way that creates a three-dimensional mesh rather than a dense, solid block.
Oh, interesting.
Yeah, and the crucial factor here is the particle size. In this 20 to 25 milligram per ml sweet spot, the particles are formulated to be quite small. So even though it's a solid, supportive concentration, those small particles allow the gel to distribute beautifully within the tissue layer.
So it blends in.
Perfectly. It provides enough scaffolding to restore volume and protect the underlying structures, but it retains the elasticity and softness of healthy, youthful mucosa. It integrates with the tissue rather than just, displacing it.
And I notice in the notes for the 21 milligram per ml products like Deserial Plus, they add something called mannitol.
Yes, mannitol.
Why are they adding a sugar alcohol to a structural filler? Like, what is it doing in there?
Mannitol is a brilliant addition, actually. It acts as a powerful antioxidant.
Oh, really?
Yeah, because when you inject a foreign substance into the body, even something as biocompatible as hyaluronic acid, the body's immediate response is inflammation.
Naturally.
Right. The body sends out free radicals that can aggressively attack and degrade that newly injected HA matrix. Mannitol essentially acts as a shield.
That makes a lot of sense.
It scavenges those free radicals, which significantly reduces the initial swelling and protects the hyaluronic acid from degrading too quickly. That prolongs both the aesthetic and functional results for the patient.
So this 20 to 25 milligram per ml range really is the Goldilocks zone. Not too soft, not too hard, protected by antioxidants, and structured as a flexible 3D mesh.
You nailed it.
But having the perfect gel is only step one, right?
Right.
Once a physician has that exact density in their syringe, how much actually goes into the tissue? Because if you inject too much of this perfect gel into a small space, doesn't it still distort everything?
It absolutely does, which is why the fluid volume calculations are so vital. When we look at the clinical trials, The volume requirements change drastically depending on the specific anatomical zone being treated. It's highly, highly exact.
Let's walk through that map then, starting from the inside, the anterior vaginal wall.
So for the anterior vaginal wall, which is the tissue near the mid-urethra, the clinical data specifies injecting exactly 2.5 millimeters of the cross-linked HA into the submucosal layer.
Exactly 2.5.
Exactly. And the placement isn't a guess. It is mathematically defined. The injection must be placed approximately 2.5 centimeters posterior and 2 centimeters lateral to the mid-urethra.
2.5 centimeters back, 2 centimeters to the side, exactly 2.5 milliliters of fluid. That level of specificity is incredible to me. Why does it have to be so exact in that specific spot?
Because that particular area is highly vascular and incredibly sensitive. Plays a major role in structural support for the urethra and in sexual function.
Oh.
You need just enough volume to provide support and hydration, but if you are off by even a centimeter, or say you inject 4 milliliters instead of 2.5, you risk compressing the urethra or creating really uncomfortable pressure.
But then you look at the posterior vaginal wall, the back wall, and the rules just change entirely. The studies show that achieving adequate augmentation there requires a much larger volume, ranging from 3 to 5 milliliters per session.
Yes, a significant jump.
Why does the back wall need double the amount of fluid?
The posterior wall endures completely different biomechanical stresses, especially related to childbirth, or simply the structural weight of the pelvic floor over time.
That makes sense.
Yeah, and the studies indicate that restoring this specific area correlates heavily with improved female sexual function scores, or the FSFI. You need that larger 3 to 5 milliliter volume to create a robust enough cushion to restore function and comfort during intercourse, which is often compromised when that tissue thins out.
Okay, so we have 2.5 milliliter in the front, up to 5 milliliters in the back. What about the outside, the labia majora?
For the labia majora, the protocol calls for 1 to 1.5 milliliters per side, so a total of 2 to 3 milliliters per session. And the depth is highly specific.
How deep?
The gel must be injected exactly between the tunica dartos and the fibrous layer of the adipose sac.
Okay, I'm going to need a visual for that. Tunica dartos, adipose sac. Where exactly are we anatomically right now?
Okay, think of it like layers of a winter coat.
Right.
The outer layer is the skin. Just beneath that skin is a very thin layer of smooth muscle called the tunica dartos.
Okay, got the muscle.
Beneath that muscle is the adipose sac, which is where the fat pads live. The practitioner has to slide the instrument beneath the muscle layer, but above the fat layer, and deposit that 1 to 1.5 milliliters of fluid exactly in that microscopic gap.
Wow, that is precise.
Yes, because if they inject too shallow into the skin, it creates bumps. If they inject too deep into the fat, the heavy HA gel just sinks and drags the tissue down further.
That sounds incredibly difficult. And amidst these larger structural injections, the sources also detail these microdosing protocols that sound even more complex.
The microdosing is fascinating.
Yeah, the Suneco Intacare protocol, okay, I'm just going to say it. It uses exactly 46 microinjections in a single session.
46.
Why on earth would a doctor put a patient through 46 needle pokes when they could just do 1 or 2 larger injections and be done with it?
I know. I understand why that sounds intense. But there is a brilliant cellular logic behind it. When a practitioner uses the Suneco's protocol, the spatial distribution is meticulous.
How so?
It breaks down to 6 injections in the labia majora, 10 in the vestibule, and 30 in the lower third of the vaginal wall. They are depositing a microscopic 0.125 milliliters of fluid at each site.
Wait, 0.125 milliliters, so it's barely a drop per poke.
Barely a drop. But by spreading the volume out over 46 tiny, evenly spaced points, they are essentially pixelating the delivery.
Pixelating, okay.
Yeah, they are ensuring an even, widespread remodeling of the extracellular matrix across the entire surface area. If you were to just put a single large bolus of fluid in the vestibule, it would pool.
It would feel like a lump.
Exactly. Microdosing guarantees superficial hydration and tissue signaling without adding any bulky, unnatural volume to highly sensitive areas.
It's like watering a garden with a fine mist instead of just, dumping a bucket of water in one spot.
Yeah.
The soil absorbs the mist evenly.
That's a great way to look at it.
But with all these different volumes being discussed, 2.5 here, 5 there, 46 microdoses, I noticed the product guidelines for Desurial specify a hard ceiling.
Yes, they do.
A practitioner cannot inject more than 20 millioles of cross-linked hyaluronic acid per person per year. It sounds like doctors have a strict volume budget they have to spend very wisely.
They absolutely do.
What happens if a doctor ignores the budget and just keeps injecting to try and get a faster result?
Overcorrection in this anatomical space is a very serious complication. Remember, HA molecules attract and bind water up to 1,000 times their own weight.
Oh, wow.
Yeah, so if a practitioner exceeds that 20 millivale annual budget, the tissue can become massively overhydrated. It becomes heavy, boggy, and distorted.
That sounds awful.
It is. It can physically compromise local blood flow, leading to unnatural chronic swelling. That 20 ml annual cap isn't just a suggestion. It ensures the body can safely accommodate the fluid, utilize it for scaffolding, and slowly degrade the HA matrix over its natural 9 to 12-month lifespan without triggering an adverse immune reaction.
It really hammers home why this is a precise medical procedure and not just a casual cosmetic add-on. You are working with strict anatomical mathematics here.
Absolutely.
But let's talk about the actual delivery, because having the right gel and the right math doesn't mean much if you put it in the wrong way. How are they physically getting this fluid into the submucosal layer safely?
The mechanics of the injection are tightly regulated, and the most critical safety step detailed in the sources happens before the plunger is even pushed.
Who is it?
The practitioner must apply gentle and sustained aspiration, pulling back on the syringe for at least 10 seconds.
10 seconds. That feels like an eternity when someone is holding a needle inside you. Why so long?
Because the practitioner must absolutely guarantee that the needle or cannula hasn't accidentally punctured a blood vessel.
Oh.
Yeah. Hyaluronic acid gel is thick and viscous. If you accidentally inject a highly cross-linked HA gel directly into the vasculature, it blocks the blood vessel entirely.
Yikes.
That causes an embolism, which starves the surrounding tissue of blood, leading to severe tissue necrosis.
Yeah.
Essentially, the tissue dies.
Okay, 10 seconds is fine. Take your time.
Exactly. Waiting 10 full seconds ensures no blood enters the syringe, confirming a safe extravascular placement, meaning you are safely outside the blood vessels, strictly in the submucosal tissue space.
That makes complete sense. You do not want to rush that step. And then for the actual delivery of the fluid, especially in the labia, the guidelines outline a very specific tracing technique.
Yes. For the labia majora, the standard protocol recommends using an 18-gauge cannula.
And a cannula is different from a needle.
Right. A cannula is blunt-tipped, unlike a sharp needle, which minimizes trauma to the tissue and pushes blood vessels out of the way rather than slicing through them. They use a linear upward retrotracing technique.
Meaning they insert the long cannula all the way to the top of the tissue and slowly inject the gel as they pull it back out.
Precisely. It allows for an even line of product. And the distribution of the fluid volume in the syringe is highly choreographed to maintain a natural anatomical shape.
How so?
As they pull the cannula back, they mentally divide the syringe into quarters. They inject 1/4 of the volume at the top pole. They release 2/4 in the middle section, where the most volume loss naturally occurs, and they deposit the final 1/4 at the lower pole as the cannula exits.
They are literally sculpting the tissue from the inside out, adjusting the flow of the liquid in real time.
It's an art form.
It is. But as precise as all of this is, the sources indicate that injecting the fluid is actually step 2. To get the absolute best results from that 20 to 25 milligram per ml gel, they have to prep the tissue first. They use synergistic technologies, specifically radiofrequency and normobaric oxygen.
Yes, and this is where regenerative medicine truly shines the concept of preconditioning the tissue environment. You can't just put top-tier filler into compromised tissue and expect a miracle.
Right.
Let's look at radiofrequency, or RF, first. The protocols detail using devices like the Sectum or Thermava to emit energy that heats the vaginal tissue to a scientifically established target, exactly 40 to 45 degrees Celsius.
And the sources emphasize that the devices have thermistors acting as a constant feedback loop, so they hit exactly that temperature range without overtreating or burning the patient. But what does heating the tissue to 45 degrees actually accomplish?
At 40 to 45 degrees, you trigger a profound biological heat shock cascade. The tissue essentially thinks it's experiencing a mild injury, so it ramps up its natural repair mechanism.
Oh, clever.
It induces neoangiogenesis, which is the formation of entirely new blood vessels. And it triggers neocollagenesis, the creation of new collagen.
Wow.
The sources even cite histological studies on swine vaginal models, which are very similar to human mucosa, showing that this specific RF exposure increased elastin concentrations in the vaginal wall by over 50% and collagen by over 100%.
That is massive structural regeneration happening before the needle even touches the skin. Okay. And then there's the oxygen therapy. The Caress Flow protocol uses a device that delivers 95% pure normobaric oxygen at a rate of 2 liters per minute directly to the mucosa. Why oxygen? I mean, we are already breathing it.
We are, but aging or atrophic tissue often suffers from cellular hypoxia.
Mm-hmm.
As we age, or as estrogen drops, the microcirculation in these tissues becomes severely impaired. The tiny blood vessels shrink or collapse.
Okay, I see.
So even though you are breathing oxygen, the blood isn't delivering it effectively to these specific cells. The tissue is literally starved of oxygen on a cellular level, meaning the cell metabolism slows down to a crawl. They stop repairing themselves.
So the device just forces it back in.
Exactly. By flooding the external area with 95% highly concentrated pure oxygen for 10 to 15 minutes, you force oxygen back into the cells and resolve that local hypoxia. You are waking the superficial tissue up.
Okay, I have an analogy for this because this prep work completely recontextualizes the whole procedure for me.
Let's hear it.
It feels exactly like aerating a lawn before you lay down expensive fertilizer. Like, if the soil in your yard is hard, dead, and compacted, you can dump all the fertilizer you want on it, but it just washes away or sits on the surface.
Right.
But if you aerate it, you punch those holes, you let the air in, you loosen the dirt, the soil is ready. The RF heating and the pure oxygen are essentially aerating the mucosal tissue. They're opening up the cellular channels, forming new blood vessels, and waking up the cellular metabolism.
Exactly.
So that when you finally introduce that perfectly measured 2.5 millimeters of 25 milligrams per ml hyaluronic acid, the living tissue drinks it up, integrates with it, and builds around it, rather than just having it sit there as a heavy, isolated lump of gel.
That is an excellent way to conceptualize it. You are optimizing the extracellular matrix. By increasing the blood flow with the radio frequency and resolving the cellular starvation with the oxygen, the tissue becomes highly receptive.
It's the 1-2 punch.
It really is. When the hyaluronic acid is finally introduced, it integrates seamlessly with the newly forming collagen and elastin fibers. You are maximizing both the aesthetic contour and the functional long-term hydration.
Biological preparation followed by precise mathematical volumization. So what does this all mean for you, the listener? If we pull all this data together, what is the core takeaway?
The core takeaway is that the era of medical guesswork in this field is over. We now know definitively that the 20 to 25 milligram per mLHA concentration provides the ideal 3D matrix. It perfectly balances structural support with necessary elasticity.
Right.
And we know that relying on precise fluid volumes ranging from those meticulous 0.125 millirel microdoses to the structural 5 millirel injections, all while strictly capping the yearly budget at 20 millirel, ensures safe, natural, and highly functional tissue restoration.
It's incredible. If you or someone you know ever finds themselves navigating this specific medical space, you now understand that these procedures aren't arbitrary decisions made on a whim. They are rooted in precise biochemistry and strict anatomical mathematics. It's a calculated, engineered science.
It really is.
Yeah.
And the rapid, constant evolution of this science is what keeps it so compelling to study.
Which leads me to a final, slightly mind-bending thought to leave you with. Some of the absolute newest, cutting-edge sources we looked at mention a new frontier, combining these highly precise HA fillers with stem cell-derived exosomes.
Oh, the exosomes. That is fascinating stuff.
Right. Now, exosomes are microscopic vesicles that act as chemical messengers. They regulate cytokines and actively trigger new blood vessel growth. So think about this. If we can already perfectly calibrate the physical HA volume and the gel concentration to rebuild the scaffolding, and now we add exosomes that literally send a chemical signal commanding the surrounding cells to regenerate, are we moving past the era of simply filling lost volume? Are we entering an era where we can command the body to permanently reverse its own cellular age?
It makes you wonder.
It really does. We started today talking about how comforting the mechanical clarity of an X-ray is for a broken bone. The diagnostic waters of regenerative medicine might still be deep and complex, but the science we are using to navigate them, it is becoming just as precise and infinitely more powerful.